Hi, everybody. It's Kevin and it's Donna, and we're so excited to have you on season 3, Donna, of the Med List. I
Yeah,
mean, it's been so much fun to do season 1 and season 2 and all the incredible guests that we've had on board.
absolutely.
Season 3, I feel like we're just absolutely loaded again with a lot of exciting individuals. So, huge thank you to everybody that's a listener, and thank you to all the guests we've had on so far. And to you, my dear colleague, we haven't seen each other for like, what's it been, a few weeks?
Oh yeah, like a whole month. Go
Oh,
figure.
that is
But
go-
it
going
was it was a
strong.
worthwhile break, right? We needed the break to recharge and to have a little bit of family time.
Amen. Yeah, we talk about, the med list, but I think the one thing that's so nice is just getting away from the world a little bit. I know you did some traveling. My family did a little bit of traveling, and it's so therapeutic, to get
Yeah.
out there and just kind of enjoy the people that love you and
Yeah.
enjoy some beautiful sights around us. So that's what we
Mhm.
did there. And speaking of traveling, you and I are both going to be traveling to beautiful Canada here during this episode.
Yes, we are.
All right. Well,
So yeah, super excited about that.
without further ado, we'll jump into season 3 of the Med List. Talk to you guys in a sec. All right. I'll add our dear guest to the stage.
Yeah. So, Kevin, I am just so excited to have Dr. Barbara Farrell with us and just so happy that she can be with us. And I want to tell everybody just a very little bit about her amazing career. So, Dr. Barbara Farrell is a pharmacist and researcher with Briere Research Institute in Ottawa, Canada, and associate professor with the Department of Family Medicine at the University of Ottawa. Dr. Farrell has over 25 years of experience with a geriatric day hospital team where she routinely sees patients with significant polypharmacy. She has research that has integrated pharmacists into primary care interdisciplinary teams. She's examined interprofessional roles in polypharmacy management and has developed and evaluated educational curriculum and mentor programs for healthcare providers. She is the founder of and senior advisor of the Deprescribing.org research team, which is just amazing. I'd like to talk about a couple of awards that she's received. She's received the Pharmacist of the Year Award from the Canadian Pharmacists Association in 2011, and she also received the Canadian Institutes of Health Research Betty Havens Prize for Knowledge Translation in Aging in 2019. She continues to work with the Canadian Medication Appropriateness and Deprescribing Network, the United States Deprescribing Network, and the planning team for the International Conference on Deprescribing. And like I said, this is just a very small amount of your amazing career, Barbara. So thank you so much for being with us.
Well, thank you, Donna and Kevin, for inviting me. And I feel like now I don't need to say anything, Donna, because I covered it all.
Well, I don't think I covered it all because we would have to be here for another 20 years to hear everything that you did. But really, truly amazing work. So I would just love to really start talking about that, right? Can you tell us more about your career and how you landed in the deprescribing world and really for a number of years too? So could you just share with us how you got to that road?
Wow. So I was thinking about this, before we were chatting. I was thinking, wow, how did I get here? And I love to say it's 25 years of experience, but really I graduated 38 years ago. So it's a little bit longer than that. I think how I got to this point with the deprescribing work that's become, more well known really started probably back even after my first graduated from pharmacy school and did my residency at McMaster, where I learned all about evidence-based medicine with people like Dave Sackett and Gord Guyot, and then worked for several years in hospital and community pharmacy. And then in 1992, I went back and did postgraduate PharmD at the University of Toronto. And that program was built on the philosophy of pharmaceutical care. And I really, really bought into the work that Doug Hepler and Linda Strand had been doing, because to me, this concept of pharmacists taking responsibility for the outcomes of drug therapy really gave me a purpose that I hadn't had to that date working as a pharmacist. When I graduated in 94, I worked for 5 years at the University of Toronto, helping to design and implement a structured practical experience program for pharmacy students. And that involved doing a lot of teaching with pharmacists about approaches that they could use to practice pharmaceutical care. So patient interviewing, different assessment approaches, documentation. I was also concurrently working in a community health center with older people and disadvantaged people, and also had a part-time job as a research coordinator. So all of that sort of fed into my role that started here in Ottawa in 1999, where I took on this role of a clinical and research coordinator in the pharmacy department here. And I was charged with starting a pharmacy research program because the Research Institute at that time was brand new. And so that's why I was hired, was to contribute as a research scientist. And, I started doing targeted medication withdrawal programs within our hospital, and began to realize that, about half the patients didn't seem to need the drug that we had stopped. And a lot of people actually felt better off their drugs. And that led into more work trying to, work with pharmacists and family doctors by integrating their practices. So as I said, when I worked in a community health center in Toronto, I was kind of an academic pharmacist. There weren't very many pharmacists working in any kind of primary care. So from 2003 to 2006, I was a co-principal investigator in a study where we looked at adding pharmacists to primary healthcare teams. And my goal there, for me, I had been working at that point for about 4 years in this geriatric day hospital practice. And I was seeing all these patients coming on 20, 25, 30 medications. And nobody had ever questioned, do they really need all of these? And family doctors were saying, help me with the polypharmacy. And I began to realize there was a role for pharmacists working in primary healthcare teams. And so that's what I've kind of focused my research efforts on the first few years. And then we started looking at, well, what do pharmacists need in terms of competencies, knowledge, and skills to actually succeed working in primary healthcare teams? And so then I was part of a group that developed an online educational program for pharmacists in Canada to help equip them to work in collaborative practices with family doctors. And that then led to us questioning, okay, now we've provided all this education, we've created these opportunities for collaborative care. Why isn't more deprescribing happening? Why are we still seeing polypharmacy? And I remember sitting around in probably 2012 with one of my research colleagues who's a social scientist, Dr. Jamie Conklin, and I said, what we really, really need are deprescribing guidelines. And that was a kind of a light bulb moment for both of us. And that really kick-started this whole effort to create guidelines that both pharmacists and family doctors could use in practice to help them figure out when and how to stop medications. That's a very long-winded explanation of how I got to the deprescribing guidelines.
But I find it interesting. And, you're back in 1999, you're saying that you were doing this targeted approach to deprescribing, if you will. Has that changed with the barriers and things like that we still see today? Was it accepted, or do we have more apprehension now? Do we have less apprehension now? Like how do you see that as, going through that? There's still an issue with polypharmacy, like you said.
Yeah. Well, we just did 2 studies of this targeted approach where we basically targeted one type of medication, and we took all the patients who were in our complex continuing care unit, and we just basically reduced and stopped the medication when the patient and the physician agreed, and then we monitored what happened. And we produced small papers that are probably not even findable on Medline because at that point I didn't really know how to publish well. But what it informed our practice at our hospital, and as we began talking about it in conference venues and such, I think it helped people realize, it's maybe it's safe to reduce and stop a medication. In my day hospital practice, I would say it's much more comprehensive. It's not targeted just at one medication. And that sometimes has been sort of my concern with the guidelines that we've produced, because the purpose of producing the guidelines was to help people do comprehensive assessments faster, more efficiently by giving them guidance for individual drugs. But sometimes what I've seen is people take that one guideline and they say, oh, okay, we're going to apply this one guideline for, say, proton pump inhibitors to all the patients in our practice, ignoring the fact that they may be taking many other medications that are more harmful than beneficial. And so that worries me a bit, that sometimes we're a bit focused on this very targeted approach when really we need to be looking at the whole person.
Yeah. I can't agree with you more on that. And I've often thought about that too. What about all the other meds that people are taking? And after that one, are there more being looked at, or are we just forgetting about every other med after that? So I totally agree with you on that. Kevin.
It reminds me a bit of a story in my very first job when I worked in hospital pharmacy. This is where I really figured out what I wanted to do. I was the ophthalmology pharmacist. So I was covering the ophthalmology ward, but our hospital, the pharmacy department, had a clinical program for inhaler counseling. So my job on the ophthalmology ward was to counsel these patients who'd had eye surgery on their inhalers for their asthma, COPD, and it made no sense to me whatsoever. But I think it's just a great example of how sometimes we are trying to establish a clinical program or an intervention, but it's not the right intervention for that patient.
Right. For sure.
That's interesting that you talk about having body systems being separated. We've got eyes in our lungs, and we're going to treat them in two kind of separate worlds, or at least we try to compartmentalize, right, to allow for staffing, scalability, and all the other things that are necessary. The one thing I'm wondering, Barb, from your perspective over these years is, when it comes to, we talked about clinicians and adopting it into practice. I've heard a lot of things about patients, right, on the other side, when the three of us have all tried to work with individual patients on, here are the medications that you're currently on. We'd like to get you off some of those medications. And we might think that for the most part, across the board, everybody wants to get off of their meds. And that's not true. Right? We know that's not true. We know that there's a lot of psychological components to staying on medications. There's some trust components related to their given practitioners and specialists. What things have you seen on that side of the fence to be able to help some of those patients to be more open to deprescribing, and especially when it comes from not their primary care provider?
Yeah. I think the key thing that I find helpful is really listening to patients to find out what's working for them. How do they know a medication is working? How do they feel about it? What medications do they not like? Very, very often, my first question to patients is, what questions do you have about your medications? And people almost always say, do I need all of these? And I say, well, one of the things we can look at while you're here is whether you do need all of these, and if they're still providing benefit, or if any of them are a problem at all. And people are nodding through all of this. So I think that that's a really key approach, is more that listening to people rather than coming in and saying, okay, today we're going to talk about stopping your proton pump inhibitor. That might take people aback. I do find, and I see patients over 8 to 10 weeks. They're coming twice a week to the day hospitals. So we can build a relationship with them over that time and some trust. And so what we will often do is start by reducing the dose of a medication that they want to reduce or stop, and monitor the effect. And so we might not stop with the most problematic medication from my point of view, say, but what might be bothersome to them. So for example, if they're having significant diarrhea, we might say, okay, these 4 medications might be contributing to the diarrhea. Is there one you think you might be interested in lowering the dose? And if I always kind of take my steps from the patient, I think that really helps a lot. And, sometimes at the end of the day hospital stay, we haven't necessarily made all the changes that we think could be done. And so we will give people information and a fairly detailed medication list that says this is a drug you might want to consider lowering the dose in the future, because as you get older, you'll likely get more sensitive to the side effects, or your kidney and liver function are not going to work as well. It's going to be harder for your body to get rid of the drug. Lowering the dose might work well for you. We also use the phrase pause and monitor, where we might pause a drug for a couple of weeks to see if the side effect goes away, but also monitor how well the drug was working. And then I document that information for the person so that they know whether or not that drug was working or was not working for them.
Beautiful. Now, I love that documentation component, and then the stepwise process of really starting with what are their internal motivations, what are the things that they really care about most, and then trying to assimilate a plan based on it. The one piece that's kind of related to it, Barb, that I'd love to hear your thoughts on is this. Deprescribing.org and a lot of the research that I've read that you've been part of is really started moving toward, which I think is interesting and very fitting, the cascade thought process, right? Looking at how does each thing go one step after the next to cause more medications to be added on board. You start with this medication, well, that causes issues that can add on this medication that causes issues that can cause another medication to be added on board. So with that, we know that because they get added on stepwise oftentimes, there is a process of taking each layer off. Unfortunately, it is not a, let's go back to the source problem, just remove that and everything else will follow. The cascade doesn't work in reverse, right, very well. And so one thing we end up seeing quite often in practice are deprescribing failures, right? Maybe road bumps, let's call them, that we go and we try to deprescribe something, and then the patient either one has an adverse effect related to that being deprescribed, or two, they had some kind of positive component related to it. Let's use an example. Benzodiazepines, for example, it was helping with anxiety, but now the withdrawal is something that's more significant, or they're not actually past some of the components that are allowing them to grieve the loss of a loved one or something else going on in life. So they still need a medication to stay on board, and they thought they were ready, but they weren't quite. How do you deal with that part, Barb? How do we as clinicians and how do patients deal with, we're hoping to do the best. We're hoping to peel back meds, and sometimes it just doesn't quite work the first time. How do you get folks to try it again and to allow that process to happen?
Yeah. So it's a complex question that you're asking. I think there's actually multiple questions in there, but I think it's important to celebrate small successes, even the reduction of a dose. Celebrating that is important. I think also bringing in the interprofessional team. So who can help with managing anxiety? How can we approach sleep better through, say, cognitive behavioral therapy for insomnia? Instead of 4 sleeping pills, can we reduce that somehow to 1 sleeping pill? Again, like different approaches, bringing in the rest of the team. So when we look at pain management, for example, we're bringing in the physiotherapists and the occupational therapists to help us with that. We're bringing in the social worker and maybe a psychologist to help with anxiety and mood management. We're bringing in the nurse to help with, say, constipation management. That doesn't necessarily mean adding, 4 laxatives. And then in terms of going back to the first part of your question, which was around these like multiple prescribing cascades, I remember I was doing a presentation on prescribing cascades when my son was in about grade 4, I think. And he looked at the picture I had drawn, which showed like this drug causing this problem, and this drug got started, and that drug got started. He said, "Mommy, that's not a prescribing cascade. That's a prescribing web." And that's always, I think, stuck with me. And that's how we've kind of presented this conglomeration of prescribing cascades that can happen. And oftentimes for me, it's going back to that initial cascade and trying to figure out, for example, the person who is prescribed a non-steroidal anti-inflammatory drug for knee pain. That then increases their blood pressure. So they get a blood pressure medication added. Then the blood pressure medication causes a cough. Then they get a cough suppressant added. Then the cough suppressant makes them feel dizzy. On the other hand, the non-steroidal drug has now increased the risk of a stomach ulcer. So they get a proton pump inhibitor added to reduce the risk of a stomach ulcer. But now they have a B12 deficiency, and they get added a B12 vitamin. So sometimes we have to draw it all out and go back to that first drug and say, okay, can we replace the non-steroidal drug with acetaminophen instead?
Right.
See if we can get effective pain control, or maybe we get a better walker, a more appropriate sized walker pain that relieves some pressure on the knee. Maybe we aim for some weight loss that relieves the pressure on the knee. And then we can potentially stop the blood pressure medications that are causing the cough, that's requiring the cough serum. And we're sort of have to go back to that very beginning one and unpick it gradually. And honestly, sometimes I feel like a private investigator when I'm trying to figure out how all these things got started and when. But quite often you can go back to one or two drugs at the beginning that you can change, and you can affect things down the line that way.
Barb, I say to the students all the time how we just sleuth at the hospital. We're the great sleuths of what could be going on with this patient. What medicine could it be?
And honestly, part of that sleuthing part could be addressed if, when people prescribed a medication, they wrote down the reason for the medication and how long they should be on it. And if then the patient, the person taking the medication, kept track of how well it was working and if any side effects happened. And then if the patients learned to say, oh, could my diarrhea be caused by my drugs? Any of my drugs?
Right.
If people could ask that question, you could prevent prescribing cascades from happening.
Yeah. And to think too that, and I know that you said it earlier, that, having people think about, oh, could it be the medicine? Like having people think about that or asking those questions. But sometimes I know, like, I'll bring my mom to the doctors and they'll say, do you have any side effects? And I'm like, how would she even know? And so I like the idea of, what are you self-treating, or what are you taking that might be over the counter, or a supplement or something like that? What are you trying to achieve with what you're grabbing yourself? Because a lot of patients themselves end up doing their own prescribing cascades, as we know. So I would love to talk a little bit more about the clinician side. And you had done some amazing work with ADAPT, and it's the adapting pharmacist skills and approaches to maximize patients' drug therapy effectiveness. And I think in this you talk about confidence too, if I have that right, and building confidence within providers and pharmacists in order to help with the deprescribing. Could you talk a little bit more about that and what might we need as pharmacists, as providers, in order to build that confidence so that we are successful in deprescribing?
Yeah. So the program you're speaking about, the ADAPT program, was an online educational program that I helped to develop and evaluate with the Canadian Pharmacists Association back from sort of 2008 to 2011. And it consisted of a series of online modules that pharmacists would take. It was sort of over 4 to 6 months. So it was quite lengthy and in-depth. They worked in small moderated groups with a moderator who provided feedback, et cetera. And the modules focused on things like interviewing skills, collaboration with physicians, documentation, evidence-based medicine. And at the time, I think about 800 pharmacists took the program across Canada. It was very effective, but because it was so intensive and time-consuming, we didn't continue after those first few cohorts completed the program. However, that work has now been integrated along with updated materials into a new program that the Association of Faculties of Pharmacy of Canada has developed with a research or an implementation team across Canada called Team Primary Care, that's looking at upskilling various healthcare providers to work in collaborative teams. And as I understand it, those modules will hopefully be offered through the Canadian Pharmacists Association in the future. And the idea, again, is to promote good medication reviews, collaboration, good communication, to give people opportunities to practice those skills, to practice using an electronic health record with cases that are developed within it, to do their documentation and then to get feedback on their documentation and communication. So that's something that's up and coming. And the early work we did with the ADAPT program did suggest that it increased pharmacists' confidence. But again, there were still, I think, tools needed. And that's where we ended up developing the Deprescribing guidelines. And there's a variety of other tools that have been developed and implemented widely since then as well.
Absolutely. So can we talk a little bit more about that too, the deprescribing.org, because that is really amazing work. So if you could tell us a little bit more about that development and how it exists, and also what you see for the future for deprescribing.org.
So as I was saying, in 2012, I kind of had this light bulb moment with one of my co-investigators, and that it would be a good idea to develop deprescribing guidelines, and the work that other folks were doing around barriers to deprescribing identified this concept that healthcare providers had access to clinical guidelines that told them when to start drugs, but they never told them when to stop drugs. And so our idea was, let's develop deprescribing guidelines that will help people decide when to stop the drug. So we applied for some funding through the Ontario Ministry of Health here at home, and we got funding to develop 3 evidence-based guidelines over a period of 3 years. So we started with a survey approach with healthcare providers who provided care to older people to find out their priorities for deprescribing guidelines. Then once we established what the priorities were, we then picked 3 topics on which we knew there were some deprescribing studies that had been done that would tell us how to recommend deprescribing. And we developed 3 individual guideline development teams who followed some very well-known, internationally accepted guideline development methods. For those of you who are interested in that, we followed the GRADE approach to deprescribing guideline development, and we actually developed the guidelines one at a time, and then after we developed the first one, we piloted it in 3 long-term care homes and 3 family practices. And then we took the feedback from the development and the piloting, and we used that to develop the second guideline. And then we did the same thing and piloted those in the 6 different sites, and then took the feedback that helped us develop the third one. So by the time we developed the second and third ones, we had a pretty good system for developing guidelines, and we also knew which tools the healthcare providers loved the best. And I just want to say, nobody really read the guidelines themselves. They were really interested in the 1-page algorithm summary that showed the steps.
Right. Yeah.
And we linked it to the guideline, and we ended up developing these algorithms. While we were developing these 3 guidelines, we got requests to develop 2 more, one for diabetes medications here in Canada, and one was a request from Dr. Emily Reeve in Australia, who actually came and did a postdoctoral fellowship in Canada to develop a guideline for when to deprescribe dementia medications. And so there are 5 guidelines developed with this method altogether. And we also had, in addition to this sort of knowledge creation approach, we also really wanted to make sure people would know about and use the guidelines. So we also had a corresponding knowledge translation approach. And so even while we were developing the guidelines, we were working on a website, and we were working on tools. In addition to the 1-page algorithm, we had a patient pamphlet, we developed whiteboard videos, we developed an app for people to use, and then we basically put all of that information on this website that we called deprescribing.org. Initially, we used another website that was linked with a larger Ontario Pharmacy Evidence Network that we were working with. But in 2015, we established our own deprescribing.org website. And then for a short time, we also hosted the Canadian Deprescribing Network on our website, but they very quickly established their own presence on a separate website, and the two sites are linked now. So basically, whenever we publish information or have new projects going on, or new resources developed, we post all that information on deprescribing.org.
That's awesome. Yeah, I think the thing that I get naturally led into after that part of the conversation, Barb, is really this. We talked about sleuthing. We talked about creating incredible guidelines, multiple guidelines, lots of money, lots of very bright people, lots of time. What would save a lot of that time in the very beginning? You know, before the show, you talked about a few things you want to make sure that the audience kind of understood. And you mentioned a couple things. You know, one of them is, you know, making sure that the providers prescribing these medications make sure that their patients understand what they're being prescribed for. What other details would be really important in the beginning to make all these things more effective? Because no matter what, you know, if we're following this guideline or that one, if we have a deep understanding or very shallow, we still have to get these basic pieces of information together. What are those, Barb? And how can both patients and clinicians do a better job of putting those up front for someone to follow behind with?
So I think from the healthcare provider perspective, again, documenting and verbally communicating as well the reason for the medication with the patient, but not just this is an antidepressant, but what symptoms should it improve for you? How can you tell it's working? How long do we anticipate you'll be taking this, whether it's 6 months or a year, or maybe because they've had a very, very serious major depression, maybe it would be longer. And similarly, you know, really with any drug, you could do that. Is it a lifelong medication? Is it an 8-week medication? And making sure that you're only prescribing it for the duration of time that you intend it to be prescribed. From the patient perspective, or the member of the public, asking the questions, what is this for? How will I know it's working? How long should I take it? When should we look at reducing the dose and stopping it? And to your previous point, Donna, you can ask, what side effects should I look for? Well, of course, we all know that the list of potential side effects is long. But telling patients, if anything unusual happens, let me know. That's helpful, because most side effects do occur fairly well timed to the starting of a drug. The risk there, of course, is some medications where side effects could start 20 or 30 years later because your kidney function has changed and the drug can no longer get out of your body easily. So therefore you have a higher level, and now you're having side effects that you didn't have when you first started the drug. And that's why we always say to people, even if you didn't just start the drug, say you've been on it 30 years ago, you still need to ask, could any of these drugs be causing this problem?
Absolutely. I totally agree with that.
And I love that she goes into, Donna, something that I wanted to get your thoughts on too, is the side effect profile component, right? And you talk about early side effects and late stage side effects overall. How have either of you two, I'm just curious to get some thoughts, how have you prepped your patients to better understand what is a side effect? Because we throw the word out there, right? And then you look at the multiple comorbidities that are going on, the other medications that they're taking, the supplements, their diet, their sleep. It becomes very complex. Like what is a side effect? What is related to the drug I'm taking versus not? How have you made it easier for folks to discern, is this a side effect? How have you basically laid out the monitoring for them to be able to make those detections early so that you know?
Well, Donna, I might have to ask you that, because I'm very rarely starting any medications in my patients.
Yeah. Well, I think part of it is, like you had said, Barbara, you know, if you feel anything different. But I love to say to people, especially our older adults, is if you're blaming something on age, it could very well be a medication that you're taking. So I feel weak. I feel tired. My eyes are dry. I don't have a good concentration any longer. I'm confused, or whatever it might be. My reaction is off. All of those things to me would mean we got to look at your meds. So anything you hear someone saying, oh, it's this, I must be getting old, it's not a good excuse.
Yeah.
I also love the whole interprofessional approach too. And one of the things that I think is really important, and I think I've said this story before, but talking to my dentist, I said, I bet you see a lot of dry mouth. And she goes, yeah, a lot of dry mouth. And I said, I hope your next question is, have you fallen? Because the same meds that cause dry mouth also increase the risk of falls. And I said, I think, so I gave a whole bunch of marketing materials on that and say, anyone who has dry mouth, you just send them my way.
Yeah.
but really, like, we can really take this interprofessional approach. So whatever anybody is feeling, we should always be thinking about, could it be a med? Whether they're just starting it, or like you said, Barb, if it's been on, for years.
I think it's helpful to explain mechanisms to people as best we can. And I don't think we do a great job of that as healthcare providers. So for example, I'm thinking of this patient. So repeatedly I hear this, my sleeping pill, it's benzodiazepine usually, it's not causing my falls. I tripped on the carpet. I, tripped on my way into the car. The floor was slippery, et cetera, et cetera. And so I've taken to trying to explain the mechanisms by which benzodiazepines can affect falls. For example, contributing to muscle weakness, and reducing the sort of reflexes that allow you to catch yourself. So what I'll say to somebody is, like, if you hadn't been taking the sleeping pill, it's possible that even when you tripped on the carpet, you may have been able to catch yourself and not fall.
Absolutely.
And the reaction I've had from patients has been like, oh my God, nobody's ever explained to me how the drug could cause that side effect. So I find that that's helpful. And then I think the other thing that's really hard to sort out is when you might have multiple drugs contributing to, for example, nausea. And I had a patient, and I want to talk about her because she actually gave me written consent to discuss her case today and in other presentations. And she came to us with really, really severe nausea and almost like vomiting whenever she tried to eat, gagging on food, etc. And she'd been put on several different medications for stomach problems, and they weren't helping. And nothing seemed to be helping this problem. And so I looked at her whole list of medications, like what could be contributing to nausea. Well, first of all, the proton pump inhibitor and the H2RA medication can both cause nausea, and they weren't helping. So we stopped those. But I'm just going to look at my list here because I've got a list of meds here. So we stopped her PPI. We stopped her famotidine. We stopped her ezetimibe, her nifedipine. She was on nifedipine and diltiazem. We stopped bupropion, which she didn't. She was like, I have no idea. I've been taking that for 30 years. I don't know if it's doing anything. We stopped her docusate. We stopped her vitamin E. We stopped her glucosamine. We stopped her digoxin. She was on bisoprolol for her atrial fibrillation. It was controlling her heart rate well. We stopped pregabalin. We stopped her domperidone, and we stopped her turmeric. And lo and behold, through all of those changes over the course of several weeks, she no longer has any nausea or stomach problems.
How many meds is she remaining on?
Well, So I gave you the list. Diltiazem, bisoprolol, some furosemide, rosuvastatin, apixaban, B12, some glaucoma eye drops, some vitamin D, a cranberry tablet, some Premarin cream, and a Symbicort inhaler. So that's what she's still on.
It's like you reduced it in half.
Yes.
Which I think we see that more often than what people can even imagine. And again, back to that whole targeted, if we target versus if we just look and see everything that could be contributing, I think that's such an amazing story. So, awesome.
I love that. Yeah, and I think the one thing I'll add on the side effect component, just like with labs, right? If someone goes and gets a laboratory evaluation and you get your labs to be able to come back in, if you don't have a baseline lab to go off of, really difficult to see where you went from point A to point B, to see if it's an upward trajectory, downward. That's your typical kind of baseline. And it's a nice thing for folks to be able to recognize there are even simple technologies like journaling to be able to help you go, I just started these medications. here's the things that my pharmacist, primary care provider, specialty team told me to watch out for. I'm going to start looking at those every evening or once a week to say, am I any better or worse when it comes to the effectiveness of this drug? Am I any better or worse when it comes to the side effects of these drugs? Because unless we write those kinds of things down and we think about them, very difficult for us to have that baseline to go off if things are getting worse or better, over time. But I do love the one thing you point out there, Donna. It is very common. Like, folks might hear the list that Barb just read off and think, oh man, that's a massive drug list. That was a small drug list, right? And with that medication list overall, that is very common for us to see more and more individuals with 15 plus medications on their drug regimen, and it fit all of the guidelines that are out there. Those are the meds they should be on. And so deprescribing ends up becoming a massive undertaking. When it comes to that massive undertaking, Barb, and you look at the team you're trying to assemble, you talked a lot about the interprofessional kind of work that's being done. What have you done for breakthroughs in Canada in particular? And then please talk across, multiple nations. What are we doing when it comes to assembling teams to better approach deprescribing? Any big wins?
So some of the work I was involved in, I have to think back now. This was 2003 to 2006. Was this? We called it the Impact Project, integrating pharmacists into family medicine practice. So we actually just had a small demonstration project. There were 7 pharmacists working at 6 family practices in Ontario. We studied what they did, what were the challenges with integration. We interviewed the family doctors. We did site visits. We looked at the kinds of drug-related problems they identified. We looked at their documentation and provided feedback. We had a mentoring program. So we worked really hard at integrating these individuals into these primary care practices. And up until that point, there had really only been pharmacists working in academic sites in Canada. So if you had a faculty of pharmacy in your city, you probably had one pharmacist working in a family practice. So we did this project, and around 2005, 2006, the Ontario government implemented funding for interprofessional, what they called family health teams. And so family health teams could decide if they wanted to hire a social worker or a nurse or a pharmacist or whatever to work in their team. So we did a really big knowledge mobilization push, and we actually mailed out Impact, how to integrate a pharmacist into your team, to all the family health team applicants in the province. And it caught on. And at this point, my understanding, and I might not have the number exactly correct, is there are about 160 pharmacists working in family health teams in Ontario. That model of practice has also been integrated into other healthcare systems in the country with varying success in different places, but is also now very up and coming in the UK and in other areas around the world, where pharmacists and physicians are working more collaboratively together in a team-based environment, where, for example, the pharmacist actually has access to all of the lab data that they need to make good decisions about medications. So that's one big thing that we've done in Canada. And the other one has been in expanding scope of pharmacist practice when they're working in community pharmacies. So this is along the lines of administering vaccines, adjusting prescriptions, independently writing prescriptions, or prescribing just for certain minor ailments. And the Canadian Pharmacists Association has a great table on their website for pharmacist scope of practice that shows you in each province what pharmacists can do. And my understanding is the goal now is to harmonize that across Canada, because there are differences between the different provinces and territories right now. And I know Danielle Pace from the Canadian Pharmacists Association has often said, your postal code shouldn't dictate what kind of service you get. And so we are trying to harmonize that across Canada. And at the same time, work collaboratively with family physicians to ensure that we are contributing, that pharmacists are contributing to care of patients and not just being a completely separate healthcare provider, but working together for the sake of ensuring patients get good medication-related care.
Barb, what do you what would you say is the response, like with pharmacists being integrated in this type of practice? Do you think more deprescribing occurs versus, say, for example, a pharmacist at a local pharmacy calling a doctor and saying this needs to, could you consider this kind of thing? Do you see that deprescribing is more activated, if you will, in these care teams like you're talking about? Because to me, it seems like that would happen.
So it's a difficult question to answer because no one's ever done like a head-to-head trial to compare. Anecdotally, from my own experience, it's easier to do these comprehensive medication reviews and deprescribing when you're working in a salaried position like myself in an interprofessional team. So that could certainly happen in a family health team. And there are these family health teams, I know of several in Ontario, that actually have deprescribing clinics where the family doctors will refer their patients to the deprescribing clinic with the pharmacist to look at completing a medication review and developing plans for deprescribing. Our research team has worked with a number of community pharmacies trying to implement the guidelines we spoke of. And that was actually very successful. The community pharmacists were able to create workflow processes and approaches to communicating with doctors who are off-site about recommendations for deprescribing, and that was very effective. We provided, again, algorithms and mentoring and advice on how to do it, but each pharmacy came up with its own approach. And that was very successful. I would think, though, if you're working in a community pharmacy and you have a patient who has 25 medications and you don't know why they were all prescribed and you don't have access to the lab data or the progress notes of the patient, that it would be hard to get started. But we could look at, for example, could you look at all the anticholinergic drugs? If the patient has cognitive impairment and falls, could we focus on reducing anticholinergic burden? So I think there's a variety of things we can do to help community pharmacists make efficient use of their time. Mm-hmm. And we also need to make sure that there are reimbursement structures to pay for that time where they are doing these medication reviews and communicating with the family doctor, because that would be quite variable depending where you live in Canada.
I know that we're getting close, and this has just absolutely flown by on me, Barb. Mm-hmm. But we did have an audience question that kind of leads into the end of what you guys are talking about there, which is perfect. So the NCPDP, puts out prescribing, electronic prescribing standards, right? What goes across the string when it comes from healthcare practitioner to a pharmacy, right? What data goes across? And you mentioned that, Barb, when it comes to, it might be hard to start if you don't have these things. So Jim asked, and I'll throw it up there for everybody to see, should we include the indication on the RX, right? And I think there's other things too that we should potentially include on the RX. Are there things, Barb, that you would say, let's phrase it this way, even if it doesn't get included in electronic standards, something that should be either documented by the patient or the clinician on their end so those records can be kept? And what things do you think should be part of that record so that, like you said, some of these collaborative efforts would be a little bit easier for folks to enter into?
Sure. So hi, Jim. Thanks for the question. I do believe that documenting the indication or the reason for the medication on a prescription is really vital. I've had conversations with people over the years about how to make that happen, and I've been told it would be challenging to push it from the healthcare provider prescriber training perspective, because it's an added workload to document that information. But that if it could be done in conjunction with requirements for electronic health record or electronic prescribing, that it is required that you document an indication or a reason, that would be valuable. Some of the challenges we might run into is that sometimes a medication is used for a reason that may not be an approved indication by the regulator. And so that sometimes is why a prescriber might be reluctant to document as an indication. Or they might, for example, if they're choosing from a drop-down menu and they don't see the reason for why they're prescribing it. They might pick another reason. And we see that in chart notes now, where we see people who are on a proton pump inhibitor automatically get the word GERD written, or the acronym GERD written beside, even if they never had heartburn in their life. That could be written beside it. So we'd have to be very careful about how we implement that. In our day hospital practice, all of our physicians write the reason for every medication addition, reduction, or cessation on the prescription, so that the pharmacist knows why it's been started or stopped, or if it's a pause and monitor, et cetera, they'll write that information on the prescription. I think the other piece that's helpful for writing on the prescription is the anticipated duration. For example, somebody's getting discharged from hospital. They got started on a sleeping pill in the hospital. They've never taken a sleeping pill before. They get sent home with a prescription for the sleeping pill. It should maybe be for 2 days, not 30 days.
That's amazing.
So things like that would make a difference. But I do think there's a lot we need to work through in terms of how to do it most effectively. But yeah, the more information that the pharmacist has, the more information they can then reiterate with the patient, who's often forgotten what the doctor told them by the time they get to the pharmacy. So I think if the pharmacist knows that information, it would be really valuable. Yeah. And for the patients to document that as well.
Beautiful.
That's awesome. I can't thank you enough for being with us, Barbara. And what I am interested to know is, just like in a nutshell, to wrap things up for us, what do you think are the most important things? I know that I'm curious on the healthcare side of things. Kevin is going to be more curious on the patient side of things. But with your wonderful career and your guidance that you've provided, what do you think is important for people and providers to know, and how can we move forward with deprescribing?
Wow, it's such a big question. I think pharmacists and physicians need to work really closely together, because we bring complementary knowledge to the equation to help decide whether a medication is appropriate still or not, and how to stop it. To that end, I've worked with the Canadian Deprescribing Network to develop a competency framework for healthcare providers to look at integrating deprescribing competencies into their prescribing competencies in their programs. So I would encourage healthcare providers to look for that. It's published in Medical Science Educator. And then on the patient side of things, I would encourage people to be knowledgeable about your medications, engage with your medications. I don't think it's acceptable anymore if someone asks you why you're taking a medication for you to say, I don't know. I think you have to know. And because if you're not taking responsibility for knowing why the medications are there and what they're supposed to do and how well they're working, I'm not sure who else is taking that responsibility. Hope I haven't gone too far by saying that, but I think as individuals, we need to be responsible for our own healthcare, and that includes knowing why you're taking medication and how long you should take it.
Yeah.
So helpful. That's a fantastic piece. And we had one last question, Barb, that I'll plug in there right before the very end. And it's a good one, because you've mentioned so many resources today. When it comes to, I guess, the clinician side of things, we have this one here for you. What is your favorite resource?
Well, of course, deprescribing.org.
What's your second one?
Second one, oh God. I couldn't say it's, well, of course, Donna's book. And actually the workbook, Donna, I have been sharing that with patients recently. And we actually want to talk to you about trying to get a bulk order. People seem to really like it. I think it gives people a way to work through the medications on their own and answer those questions and to take that responsibility. But other resources I use are the Canadian Medication Appropriateness and Deprescribing Network's website. Has a lot of useful information. The United States Deprescribing Research Network, the Beers criteria information from the American Geriatric Society. I use something called the Anticholinergic Burden Scale Calculator. It's an online calculator. It helps you figure out how much your medications are contributing to cognitive impairment and falls. Those are a few examples, but there are many, many, many more. The Loan Institute has information. The NHS in the UK has a lot of great information about polypharmacy and approaches to polypharmacy management. So I could go on and on. There's so much information out there. There's really no excuse that we shouldn't be able to do this.
Yeah. Yeah.
I love that. That's a good call to action there, Barb.
Yeah. And the other call to action that we would love to share, and I love all the people who have been online with us today and your comments, and thank you so much for listening in. But please make certain to share our podcast, The Med List, with others. Take a listen. Please review, like us, subscribe to us, and please spread the word. So, and Kevin, I know you love to list everywhere we are.
Oh, yeah, it's one of my favorite things of all time. Here on YouTube, on LinkedIn, on Facebook, on Apple, on Spotify. I think I got most of them there, Barb. It wasn't as good as your resource list, but those are the social. It's really similar to the work that Barb's been doing over her career. I think Don and I really just enjoy bringing folks like Barb to an audience to be able to hear all the things being done to make people more cognizant of the impact of medications on their overall healthcare journey, and how deprescribing can be a major part of that. And medication optimization is a big piece of that, both from the patient side, as Barb mentions, if you're not looking out for yourself, then who is? And from the provider side, when it comes to you have to collaborate with an entire group to make it all work. But anyway, I'm so thankful for you, Barb. Really enjoyed the conversation, your wealth of knowledge. I'm very thankful that you are continuing to practice 2 days a week and stay engaged in the community. We sure look forward to keeping up with you and hopefully having you on again sometime soon.
Awesome. Well, thank you so much for inviting me.
Amazing.
Awesome. Well, thank you all for hopefully enjoying the first episode of season 3 of the Med List, and we'll catch you all next time.